Welcome everyone to another brief presentation, this time looking at rheumatoid arthritis, particularly with regards to its presentation in the hand. Now before starting, it's important to note that rheumatoid arthritis is a systemic autoimmune condition that will affect multiple joints and multiple systems of the patient. Their effect on a patient's hand can have quite debilitating consequences and can be at times incredibly painful. This is why the utmost care must be taken if examining someone with rheumatoid arthritis to not cause any more pain. So if we look at the first slide and just some simple definitions and what is going on with regards to rheumatoid arthritis in the hand. Now obviously we know that rheumatoid arthritis affects the synovial lining of multiple joints. This inflammation of the synovial lining, or synovitis, can cause multiple problems, including but not limited to compression of tendons, nerves, and eventually joint erosion. Through a complex cell-mediated immune response involving T cells, you will have significant immune responses against soft tissue, cartilage, and finally bone. This bony reaction, which is caused by increased osteoclastic activity, will lead to subsequent bone erosion and eventually destruction. If we move on to the second slide and try and summarize some of the symptoms that patients will complain with having rheumatoid arthritis, these can be looked at as a direct consequence of the aforementioned inflammatory response. So therefore, patients will be complaining of significant pain, swelling, and functional disturbances in day-to-day activities depending on the severity of the rheumatoid arthritis disease in their hands. The picture shown in slide 2 demonstrates quite nicely someone with advanced rheumatoid arthritic disease, and already you can imagine the difficulty that this patient will have with fine motor movements. This picture quite clearly demonstrates, however, that this person has been living with rheumatoid arthritis for a potentially significant amount of time. Symptoms can be far more subtle, particularly in the early stages of the disease, which is why your questioning during your history taking is vital. Look for signs such as early morning stiffness, with function that improves with movement, to differentiate rheumatoid arthritis from its very close relative osteoarthritis. The patient demographic will also differ in that patients with rheumatoid arthritis may often present at a younger age and have extra articular signs and symptoms. If we were to move on to the examination of a rheumatoid arthritic hand, we can still use the principles of look, feel, move, and perform any special testing. The proviso to this, of course, is to not cause pain. For the examination of the hand, it is equally important to ensure adequate exposure of the patient's elbow, forearm, and wrists. This is because extra-articular manifestations of rheumatoid arthritis, such as rheumatoid nodules, are seen in almost 25% of patients that live with rheumatoid arthritis. These can often be seen as quite large protuberances over the olecranon and ulnar border of the forearm. Moving distally, you may notice ulnar subluxation of the distal ulna, radial deviation of the wrist, and a Z deformity at the thumb. I would also stress the importance of knowing the names of the individual hand joints to allow description of the deformity to be much easier. This will show in an examination setting that your au fait with these medical terms and will score you high praise with the examiner. In the picture demonstrated in slide 3, you can clearly see that the metacarpophalangeal joints are significantly swollen in both hands. Looking closely, I would also suggest examination of the proximal interphalangeal joints, as they can often be swollen and tender. The distal interphalangeal joints, however, are often spared in rheumatoid arthritis. The picture quite clearly and nicely demonstrates the ulnar deviation of the digits in relationship to the metacarpophalangeal joints. You may also get eponymous deformities of the digits, including swan neck deformity and Boutonier's deformity, described on the slides. Don't forget to assess for the patient's active range of motion in the fingers, as this can often highlight their reduced function, which can be secondary to tendon rupture. This is often seen in the extensor tendons of the hand and will present with an inability to extend the digit at the metacarpophalangeal joint. Don't forget to look for other joints that are affected with rheumatoid arthritis as part of your completion of examination. Investigations for this group of patient has to be done in a multidisciplinary team setting, with the primary team leader being the rheumatologist in charge of the patient's care. If you are in the early stages of diagnosing the disease, then inflammatory markers such as ESR and CRP will often be helpful. However, certain people will also have positive testing to rheumatoid factor and anti-CCP. This can often be done in both primary care or in secondary care when the patient sees a rheumatologist. These antibodies have varying degrees of sensitivity and specificity, which may ultimately have a bearing on how the patient is managed medically. Imaging techniques such as plain film radiography, CT scanning, and MRI scanning will help diagnose both bony and soft tissue pathologies in the hand. If in doubt, a plain film radiograph will often be a good starting point. Depending on the severity of the disease, you may find reduced joint space and significant bony erosions. Similar to investigations, management of these patients has to be done in the context of a multidisciplinary team setting. The rheumatology team will take the lead on medical management, and that will depend on the subtype of rheumatoid arthritis that the patient is suffering with. Of course, in the initial setting, both primary and secondary care physicians can prescribe physiotherapy, splinting, analgesia, and education tools to allow the patient to live with this condition as best they can. This will often be in conjunction with best medical management. For patients that have a significant functional problem secondary to the rheumatoid disease of the hands, a specialist orthopedic referral is often warranted. This will involve looking at the specific deformity in question and correcting it appropriately. To give an example, metacarpophalangeal joint subluxation and dislocation may well be treated with a combination of arthroplasty or fusion. Similarly, as mentioned prior, if tendons are injured, damaged, or ruptured, then the orthopedic surgeon would have to look at the reasons why and either repair, reconstruct, or relocate the tendon. This will hopefully allow some semblance of return of function to the patient and therefore improve the quality of life. To summarize, this is a very brief presentation looking at specifically changes related to rheumatoid arthritis in the hand. These changes can be debilitating, painful, and significantly affect a patient's quality of life. Be mindful not to cause the patient pain, and Remember to revise the anatomy of the hand joints in order to be able to describe the deformities appropriately.